Hi, my name is Matthew Crane, and this is Highest Yield, the world's newest podcast for Step 2 CK and NBME Shelf Review. I'm a fourth-year med student, currently on a research year, and Step Review podcasts were hugely important in my Step and Shelf preparation. I liked them enough that I wanted to start my own, so here we go. I thought we'd start out with some more psych-heavy topics, with integrations to other areas as well. Anyone who's taken a shelf knows that they don't stay very neatly confined to the subject you're studying, so it pays off to know some overlap. My hope with this podcast is to focus on the hardest part of Step 2 and NBME shelves, connecting patient presentations and differentials to diagnostic steps to treatment. We're all about the highest yield here, so let's get into it. Substances are an outstanding place to start. There's lots of features that are dead ringers and help you narrow things down really quickly. Let's start off with some scenarios. You've got a patient who's super aggressive, picking fights left and right. They might have high pain tolerance. They might even start fighting you while you're treating them. When you look at their signs and symptoms, they've got tachycardia, they're hypertensive, and they're hyperthermic. Characteristic eye findings you'll see, always important in talks. We're going to see multidirectional nystagmus. Could be rotary, horizontal, or vertical. They may also have meiosis. So what's the drug we're talking about here? Yep, this is PCP. And what's our test? We're going to use a urine tox to make that diagnosis. And what's our treatment? As with quite a few tox problems, there's no antidote. We're going to treat these patients by helping them back to homeostasis while they clear the drug. These patients are tachycardic, aggressive, hypertensive. Treatment's going to be benzodiazepines. Moving forward, you've got a patient, a Wall Street executive. He comes in, tachycardic. He's got recent weight loss, hand tremor. Pupils are dilated up to 8 millimeters. He seems nervous or anxious. So what's your initial differential? With toxicology, it's always helpful to think in terms of toxidromes. What we're describing here is a sympathomimetic toxidrome. Your instinct might say cocaine because I said Wall Street exec, and I think that's great. You also want to think about amphetamines. Maybe this exec is working late nights and using Adderall to get ahead. And what's our test in either case? It's going to be a tox screen. And what's our treatment? Well, it varies a bit by the drug and the severity. For cocaine, if the agitation is not too bad, we can use benzodiazepines. If agitation is bad and they're psychotic, we're going to antipsychotics, like haloperidol. Symptomatic support is also important. Cocaine is vasoconstrictive, and it can also cause an MI. It can also cause a brain bleed or a stroke. And the key pathophysiology to remember is vasospasm. If cocaine does cause an MI, let's say you get a big STEMI with ST elevations in 2, 3, and AVF. You're going to move forward with most of your typical ACS regimen, but you're also going to want to include benzodiazepines for those cocaine-induced ACS incidents. Importantly, and very high yield, what medicine would you typically use in treatment of ACS that we would not use in cocaine intoxication? It's going to be beta blockers. Instead, you can use some alpha blockers, like phentolamine. This is very high yield to remember because it's got a pathophysiology tie-in. Cocaine stimulates alpha and beta receptors. If we give them beta blockers, it's going to lead to that unopposed alpha, which in theory could clamp down vessels hard and cause really bad hypertension and heart ischemia. As I understand, there's some literature to dispute this in practice, but it's a really classic board question you'll want to remember. No beta blockers for cocaine intoxication because we don't want that unopposed alpha. And real quick, while we're talking about alpha blockers, we have two non-selective alpha blockers. Which one is reversible and which is irreversible? For phentolamine, that's going to be our reversible one. We give that for cocaine hypertension and patients on MAOIs who eat food with tyramine, like wine and cheese. The irreversible alpha blocker we're thinking of? Phenoxybenzamine. And that's really used for pheochromocytoma. Now let's step back a bit to talk about our differential a minute ago. Cocaine and amphetamine intoxication. If your tox screen shows amphetamines, your treatment is going to be mostly the same. Give them fluids, control the hyperthermia, control the hypertension and any arrhythmias that might come up, and use benzos for seizures or agitation, or Haldol for severe agitation or psychosis. That's haloperidol. Now let's say you don't have tox screen results. All you have is the patient with sympathomimetic symptoms. And they ask your treatment. Do you need to have diagnostic tests to know your next step? Ultimately, in this case, no. If all we have is a patient with a toxidrome, we can treat the toxidrome. That's a cornerstone of modern toxicology. Give benzos and look out for other complications that we need to treat, like hypertension. This is an aside, but in the old days, when patients came in with a sedative hypnotic toxidrome, think about a patient who's sedate, not breathing, like an opioid overdose. The old approach used to be to give the patient stimulants. We thought, hey, we should wake this guy up. And in the 1940s, they came up with the Scandinavian method for barbiturate poisoning, where they didn't try to stimulate these people. They just supported their airway, gave oxygenation or ventilation and fluids, and waited until the patient cleared the poison. The same principle is true for a lot of our toxicology, where we don't have a clear antidote. So let's think of another toxication problem. You've got a young boy with really brief episodes of seeming drunk, probably brought in by his parents. He might have a little bit of eye redness, and the real key here is that he'll probably have a rash between his top lip and his nose. So what's our drug? This is going to be inhalant intoxication, and that rash is called a glue sniffer's rash, from where they have to put the inhalant can to actually get it into their system. And now, how about a weird one? We have a patient who's been using marijuana for years, multiple times a week. She's got this pattern of symptoms that comes and goes. She's got abdominal pain, nausea, and vomiting. And here's the key. When she takes a hot shower, that nausea and vomiting get better. So what's going on? This is cannabinoid hyperemesis syndrome. I know it sounds niche, but it's high yield, and the presentation is super specific. They can throw a lot of other details in the question to bog you down, but just remember, heavy cannabis use, nausea, vomiting relieved by shower, cannabinoid hyperemesis syndrome. And what's going to be our definitive treatment for that? Yep, they're going to have to stop using cannabis. Now, a big topic is smoking, and we all know the presentation of smoking, but the questions you'll get will relate to the stages of change as well as pharmaceutical interventions. So let's talk about the treatment. It's important for the test, and it's important for your patients. 3 big options. Number 1, nicotine replacement. That can be gum, lozenges, patches. It just replaces the tobacco with other nicotine. It'll reduce cravings and reduce withdrawal. Varenicline is our second option. That's going to be first line, and it reduces cravings and it reduces withdrawal. Bupropion is our third option. And remember, that's one of our atypical antidepressants. It reduces cravings and, again, going to reduce withdrawal. Now, another drug question. Let's say you have a patient with those sympathomimetic effects we saw earlier. They've got tachycardia, hypertension, body temp is a little high. For this scenario, let's say it's a college student, and he was out dancing tonight. Pupils, always important in toxicology, they'll be very dilated. And he might also be grinding his teeth. So you take a look at his labs, and you see a sodium that's under 135, meaning he's hyponatremic. What's your differential going to be? Top thing should be MDMA, or ecstasy. The bruxism is characteristic, but a lot of the presentation is going to overlap with cocaine or amphetamines. And so unique to MDMA, it causes this dehydration. The patient's going to drink a lot and dilute their sodium. So hyponatremia gets you the diagnosis. Treatment is supportive. We don't have an antidote for that one. As an offshoot of this question, let's say you have the same patient. He was out dancing, came in with those symptoms, and you figure he's got MDMA on board. But his presentation has a few other features. Namely, he's got these myoclonic jerks. He's outright hyperthermic. He's sweating profusely. He's confused. He's got rhabdomyolysis, and he's going into renal failure. Maybe his mom tells you he's being treated for depression. So what's the side effect he's experiencing? That's right, this is going to be serotonin syndrome. This patient's also on an SSRI. So the classic serotonin syndrome case is going to be when someone is switching from an SSRI to an MAOI without a good washout period. This is a sneakier way to bring it in, though. MDMA is serotonergic. So while we're on the topic, what's the general time period for how long you would have to wait between SSRIs and MAOIs? That's right, it's going to be 2 weeks in general. For another tox question, you've got a patient, comes in unresponsive, very slow respiratory rate, let's say 6 or 7 breaths per minute. Pupils are 1 to 2 millimeters, and SpO2 is dropping, it's at 88%. And if they're feeling really nice, they'll tell you he has track marks on his arms. So what's the drug? Probably heroin. This is an opiate overdose. We get that by the pinpoint pupils and the respiratory depression. And what's the treatment for that? Yep, it's going to be naloxone. And you're going to repeat that as necessary if it starts to wear off. Aside from that, you're going to always follow your ABCs. If he can't breathe, we're going to have to help him and provide some ventilation. Something that catches people sometimes is how do you know this situation isn't a benzodiazepine overdose or an alcohol overdose? Benzodiazepines or alcohol would cause respiratory depression, but they wouldn't cause that meiosis. And let's say we knew it was a benzodiazepine overdose. What's the antidote that we know from our Step 1 studying? That's right, it's flumazenil. But important for Step 2, we don't really use it in practice. It has a really high risk of seizures because it causes this immediate withdrawal. So benzo overdose is not usually going to kill someone unless they have a few other co-ingestants, things like heroin or alcohol. Now, a few more drugs I want to hit today. Let's say you have a patient with that sympathomimetic toxidrome, hypertension, tachycardic, hyperthermic. They might also be covered in excoriations. They have scratches all over their arms. Their pupils are super dilated, and when you look at their teeth, you see severe decay. So what's our drug? That's going to be methamphetamine. In treatment, you're going to treat the toxidrome. Just like cocaine and amphetamines, you're going to give benzos for agitation or seizures and haloperidol for acute psychosis. Watch out for other complications. As an offshoot, another weird question, let's say you have a patient who has that sympathomimetic profile. They're hypertensive, tachycardic, and hyperthermic. Pupils are dilated, and they're altered. But the key is they've been altered for a long time. Maybe they've been wandering for a few days in the streets. It looks like a really prolonged amphetamine overdose. What are we dealing with? These are bath salts. Once they were kind of oddly implicated in turning people into zombies, but their hallmark is going to be those long symptoms, and it won't show up on a tox screen because they're synthetic. So the treatment is supportive. Let's talk about a few defense mechanisms. Some of them overlap, and it's important to know the differences. Let's say you have a patient comes in, he feels really guilty about cheating, and so he accuses his wife of cheating. What's the defense mechanism? Yep, this is projection, where he is projecting his emotions to another person. Let's say you have a patient and she feels really angry at her boss, and she takes it out by yelling at the kid bringing coffee to the office. What's this defense mechanism? This is displacement. You're shifting the emotion from one person who's kind of threatening to you, like your boss, to another who's less threatening. Maybe that's a subordinate, maybe it's just an innocent bystander. And another one, a third one that I want to talk about that gets confused with these two. Let's say the patient's married, but he's having a crush on his coworker. And instead of being extra nice to his crush, he insults her daily, or he picks on her ruthlessly. What are we dealing with? Yep, this is reaction formation. In this case, we have an unacceptable impulse. Here, it's his attraction to his coworker. And to avoid that anxiety about the crush, he does the exact opposite of what he'd like to do with that impulse. So you want to keep those three separate: projection, displacement, and reaction formation. Another classic one that's easy to get, patient has a terminal diagnosis. Instead of having an emotional response, they'll focus on reading lots of studies. You'll come into their room and they'll tell you to look at all the newest tables and figures on these papers. What defense mechanism are they using? Yep, this is intellectualization. I want to talk about two big mature defenses also. Let's say you have a patient who's a college student. He's got a rough background, gotten lots of fights when he was young. He has a lot of anger, but he becomes a champion athlete. He funnels that anger to gives him drive. What are we dealing with? Yep, this is sublimation. The second mature defense I want to talk about, let's say you have a patient. They're a nurse or a resident, and they're afraid of blood, but they push down that fear to take care of their patients. Another example could be someone afraid of heights, but they'll push down that fear, and they'll climb out on a ledge to help their cat. This is a conscious action. Someone is pushing down their anxiety to get things done. What are we dealing with? This is suppression. And we're going to contrast this real quickly with an immature defense, which is repression. Repression is unconscious. Someone may lose memories of a bad event from childhood. That's repression. Other mature defenses, you might hear about altruism, like a donation as part of the grieving process, or you might hear about humor, like making jokes despite a serious illness. Those are a little bit less common on test day. And let's close with some quick questions on pharmacology. Psych has lots of drugs. They have important effects and side effects. So here's your scenario. You have a patient, they just finished surgery. Soon after the anesthesia is given, or they just started surgery, I'm sorry. Soon after anesthesia is given, they have muscle rigidity, they're sweating heavily, and they have this impressive hyperthermia. They're tachycardic and their blood pressure's high. What's your diagnosis? Yep, this is malignant hyperthermia. And is there an inheritance pattern for this? That's right, it's going to be autosomal dominant. What happens is the ryanodine receptors, when they're exposed to these volatile anesthetics, especially succinylcholine, they get an accumulation of calcium in the muscle, and that's going to cause breakdown. So what's your immediate treatment? As with most drug side effects, step number 1, the easiest step, is to just discontinue the causative agent. Step 2 in this case is dantrolene. You're also going to keep them oxygenated and use cooling measures like ice packs. So let's talk about the main one that gets confused for malignant hyperthermia. Separate scenario, you've got a patient, and she comes in with hallucinations, agitation, and this acute psychosis. So you're going to give her a high-potency, first-gen antipsychotic, things like haloperidol or flufenazine. And after you give it, you notice she's really hyperthermic, running very hot. She has rigid muscles. A buzzword could be lead pipe rigidity. She's altered and has autonomic instability. And when you look at labs, you see her creatinine kinase is high. What's your diagnosis here? It's going to be neuroleptic malignant syndrome. You might also see leukocytosis, and you might see myoglobinuria as well. Treatment here, once again, discontinue the antipsychotic and give supportive care. But specialized drugs that we're going to use, dantrolene is an option. Dantrolene works by preventing calcium from moving through the myocytes. It prevents that muscle contraction. And it works the same way for both malignant hyperthermia and NMS. Other drugs you can consider for NMS, you can consider dopamine agonists like bromocriptine. But remember, you don't use bromocriptine for malignant hyperthermia. And something odd to remember, a possible presentation of this could be antiemetics like metoclopramide because of that dopamine antagonism. You could easily have a question about hyperemesis gravidarum in a pregnant woman. She starts metoclopramide, gets lead pipe rigidity and high CK. Your diagnosis is NMS. Last one, let's say someone takes a TCA. Maybe they have major depressive disorder and they're taking amitriptyline. Maybe it's a kid who's been taking imipramine for nocturnal enuresis. Either way, they take a lot of it. So what effects are we going to see? Things to keep in mind are those ham side effects: antihistamine, antiadrenergic, antimuscarinic. But what else do we have to worry about with TCAs specifically? Maybe seizures or CNS toxicity, but what has the most treatment relevance for us is going to be cardiac toxicity. If you see QRS prolongation, our treatment is going to be sodium bicarbonate. I want to end on a few quick review points for the highest yield items today. If you have an aggressive patient with multidirectional nystagmus, you want to think about PCP. You have a patient with a sympathomimetic toxidrome. It could be a lot of things. It could be cocaine, amphetamine, methamphetamine, MDMA. We look for some other localizing clues. Cocaine, think about cardiac issues or nasal symptoms. Methamphetamine, think about skin excoriations and tooth decay. For MDMA, think about that bruxism and that hyponatremia. And always read the scenario behind what the clinical presentation is. Remember that MDMA can cause serotonin syndrome. Most commonly, it'll be someone taking MAOIs and SSRIs without that 2-week washout, but you want to keep in mind unusual presentations. Cocaine intoxication, don't give beta blockers because you don't want that unopposed alpha. If you see a rash between the upper lip and nose in someone with really brief intoxication, think about that inhalant abuse. For heavy cannabis use and nausea vomiting relieved by shower, think about cannabinoid hyperemesis syndrome. Treatment there, stop the cannabis. Smoking cessation options, you got nicotine replacement, varenicline, bupropion. For opioid overdose, you're going to see pinpoint pupils, track marks, and depressed breathing. You're going to treat them with naloxone and ventilate them. For a benzo overdose, the breathing's not going to be as depressed, usually not fatal. Support them with ventilation. We don't really use flumazenil these days. Defense mechanisms, we talked about projection, displacement, reaction formation. Those have a lot of overlap to be careful about. In mature mechanisms, big ones are suppression, where you push it down consciously, and sublimation, where you're channeling any unhealthy impulses. A few pharm questions we talked about. If you get an anesthetic and you see rigidity and hyperthermia, you're going to worry about malignant hyperthermia, which again is autosomal dominant. Treatment is dantrolene. If you give an antipsychotic and you see rigidity and hyperthermia and a high CK, you're going to think NMS. Treatment is dantrolene or dopamine agonists like bromocriptine. And remember, just like MDMA and SSRIs can cause serotonin syndrome, and it's not the first thing you'd guess, metoclopramide has some similar effects to antipsychotics due to that dopamine antagonism. it can cause the same extrapyramidal side effects and NMS. And if someone has TCA toxicity with a wide QRS, treatment is sodium bicarbonate. If this was helpful, please take a moment to leave a review. This content is produced for educational purposes only, and this should not be considered medical advice. Until next time, I'm Matt Crane, and this has been Highest Yield. Please feel free to reach out to me on Twitter. My username is @MatthewA_Crane with any questions. Thanks so much.